has authored several research articles on improving the outcome of patients with advanced liver disease. Dr. Rahimi has also completed numerous peer-reviewed publications and serves as a medical journal reviewer of the Clinical Gastroenterology and Hepatology, Alimentary Pharmacology and Therapeutics, Journal of American Medical Association, and Nutrition and Clinical Practice. So we have a really esteemed panel, as you can see up here. And what I'd like to do is start our fireside chat by some pre-questions like we do. You guys are going to make them dance now, right? While they're eating? All right. How do observed increases in plasma EPO levels compare between ESA and HIF-PHI treatment? Are both therapies induce comparable increases in plasma EPO levels? Do ESAs induce more moderate increases in plasma EPO levels? Or do HIF-PHI induce more moderate increases in plasma EPO levels? Make them dance. All right, we're pretty split here. Most of you thought it was the third answer with HIF and PHI. We'll get back to it a little later, but you can see the outcomes of that. Second question, a patient with HER2 positive, advanced GI cancer, treated with trastuzumab, presents to the emergency department with dyspnea, dry cough, and mild chest pain. The patient explains symptoms are causing interference with activities such as shopping and preparing meals. What grade of adverse events does this most reflect? Is it grade 2, 3, or 4? Music. All right, well, most of you thought it was 3, but a lot of you thought it was 2, and a small portion thought it was 4. So we'll see what Dr. Christensen thinks in a few minutes. Prophylactic therapy with lactulose and rifaximin is recommended. Now, we haven't had this talk yet, right? But let's see how you guys do. With lactulose and rifaximin is recommended by both the American Association of Study of Liver Disease and European Association of Study of Liver Disease, following which of the following? Second episode of overt HE within 6 months of the first, second episode of HE in 6 to 12 months after the first, and second episode of overt HE regardless of the time frame. So do you do it regardless of time frame within first 6 months or after the first 6 months? Do you add on prophylactic therapy with lactulose and rifaximin? All right, so most of you thought that you do it regardless of the time frame. You should do it in overt HE. Dr. Rahimi will define for us overt HE shortly also. So it seems to me like, one of the themes here that we're trying to get at to our esteemed panel is the concept of prevention and prophylaxis and proactivity. You kind of see it come up in several contexts, regardless of the specialty that we're dealing with, right? When you talk about CKD and anemia, we talk about what are some impactful advantages associated with the use of HIF stabilizers, So that may be it would be good to hear from from Dr. Palmer regarding that question. We're going to hear from Dr. Rahimi around, how should we be thinking about prophylactic prevention of HE and hospitalized patients? Is it one therapy, two therapies? Is it based on symptoms? What's the management plan from the outpatient? Because we don't want to be admitting these patients into the hospital, so we'll ask him to talk a little bit about that. And then, you heard from, in terms of adverse events, the goal is to try to minimize it, and how can hospital-based clinicians balance the need to respond to treating patients in acute distress as well as evaluating the events as part of these adverse events. And then do I need to keep them in the hospital to actually do that, or do I move them to the outpatient setting is the other kind of big question here to manage all of that. So I'm going to just open it up to each of you to kind of put this in the context of proactivity and prevention, because you all have you all are in the space right now of some phenomenal therapeutics that are coming out. But with each one of these therapeutics, there are obvious potential complication issues that we want to both avoid and utilize in the right way. So, Dr. Palmer, take it away.
Yeah. So let me begin by first addressing that question. Remember, when you think about what the PHD2 inhibitors do versus erythropoietin-stimulating agent and the EPO levels that result. So when you give it exogenously through an injection or a subcutaneous administration, you're going to get a huge rise in systemic levels that then fall down, and then presumably you start seeing red blood cell mass increases. These PHD2 inhibitors, remember, are in essence mimicking a hypoxic state, and so calling upon your own body to synthesize EPO. So if you follow, and these studies have been done, the EPO levels just very gradually go up, and they never have these huge swings. So they're very minimally above normal, but yet they still then produce the increase in red blood cell mass. So it's much more physiologic. And in addition, as we pointed out, it enhances the iron homeostasis so that you get increased utilization of iron and increased absorption. And so the advantage of this new therapy, should it become available, is that we can really overcome the current barriers to our CKD population, where people who are not yet on dialysis, it's hard to institute these injections and get people to do that and have all the infrastructure involved for teaching. Whereas if you were to be able to give a pill once a day, which is what these drugs are, perhaps we could begin to address the anemia earlier. And again, because of the association with quality of life measures, the association with less heart failure and the like, it really has an advantage to proactively address this issue.
Great, thank you. Dr. Rahimi?
Well, I'll start by saying thank you for having me, Integrity. And you have not had the lecture. Is this on?
Yes.
Okay. You have not had the lecture, but let me describe what hepatic encephalopathy is. Hepatic encephalopathy, or HE, is a neuropsychiatric reversible condition that up to 50% of patients with cirrhosis or chronic liver disease have. So it's usually a buildup of portal hypertension, which we'll go over the lecture in a little bit. And that portal hypertension, which can be caused mostly, or there's about 10 different causes of cirrhosis. It's not just alcohol or Hep C. Now it's actually fatty liver that is becoming more prevalent. Over time, these patients develop confusion of the brain. And we'll go into the pathophysiology. But the standard of care at this point is giving lactulose therapy, which is non-absorbable. It causes bowel movements, so you can have bowel movements and get rid of the toxin. One of the pathophysiologic mechanisms is ammonia. The secondary medicine, which we'll talk about, the FDA label is rifaximin, where it's additive therapy after a patient has failed lactulose therapy and has gone readmitted. When you get admitted to the hospital, that's overt HE. The ones that are on outpatient basis, that we call it covert or minimal HE. And so once they have failed lactose therapy and get readmitted, that's what the current FDA label is, so you can give rifaximin, which is a non-absorbable antibiotic. And we'll talk about that a little more.
Great. Dr. Christensen.
Yeah, I think from my perspective, recognition is the most important thing. If you don't know what the patient's on, then you can't recognize that they could be dealing with an adverse effect that's different. In cancer, we've made huge gains in terms of survival in the last 20 or 30 years, and that's dependent on the type of tumor, but if you look broadly, actually, all tumor types have improved. And that's not because our cancer therapies and oncologists are getting more brilliant, it's because supportive care is improving. And so if we do nothing in the next 10 years, but keep the exact drugs we have now, I expect our outcomes will be better because we're getting better at supporting that. And part of that is that people, the entire medical community, can start to recognize some of the things that can happen to these patients. So I think prompt recognition is important, and I think prompt discussion with the oncology team and saying, I don't think you're ever wrong saying, hey, could this be the drug you're giving them? Could you be doing this to them? Because if you don't do that, then I think that these patients can get very, very sick very quickly if they're not intervened on. So
let me change the conversation just shortly, really quick. But one of the things hospital-based physicians are put under pressure, and you guys serve in that role also from your subspecialty area, but one of the things we're faced under a significant amount of pressure on is length of stay and moving patients through the system as fast as possible. The other thing that we keep hearing is that, it's so costly to have inpatient, that the world is moving to the outpatient side. At the same time that I've been hearing that, I don't see that happening because, our hospital most of our hospitals are running at full capacity, right? So in your specialty areas, where do you see things going here? Are we moving towards more outpatient care, and is it getting balanced because we're adding more therapeutics that are leading to patients living longer and creating more toxicity? So it's shifting. What it feels like that's happening is the bread and butter asthma and COPD that used to come in is no longer coming in. But what is coming in is these very complex patients that are having complexities from the new novel, some of the novel therapeutics that are there, and the fact that they're living longer. So what from your different specialty areas, how do you see all of this work?
Yeah, I mean, something that we really haven't discussed so much in my presentation, we have really some new therapeutics in the field of nephrology that I think are going to make a definite impact. The SGLT2 inhibitors and a new drug that is a non-steroidal mineralocorticoid antagonist. These drugs have been found to have kidney protective effects and cardiovascular protective effects beyond our current standard of care, which is the use of renin-angiotensin system blockers. Just to kind of put it into perspective, for the last 30 years, the only thing that we as nephrologists really had to offer was the ACE and the ARBs as a kidney protective effect. But with these new drugs, SGLT2, the non-steroidal mineralocorticoid antagonists, these are now really exciting drugs, and I think we now have really an opportunity to slow things down, lower cardiovascular event, reduce heart failure, hospitalizations, and the like. And so hopefully in the next several years, we'll start to see that really translate into the issues that you're talking about, the crowded hospitals.
Well, the other thing about the SGLT2s is that it's hard for anybody to own them. It's not the endocrinologist drug, and it's not the nephrologist drug, and it's not the cardiologist drug. It's actually now becoming almost everybody's drug, right? So because of its impact. So any thoughts, Dr. Rahimi?
Yes. I don't know if my mic's working.
All right, let me move to...
Is it better?
Yeah,
okay.
Go ahead, Dad.
So it's interesting. That actually is a great transition because we just had our liver meeting in Washington, D.C., and we were talking about, fatty liver is really prevalent now. And looking at these drugs, I think it's actually going to be the treatment because a lot of companies have failed in figuring out a cure, like a pill or an injection. And I do a few clinical trials for NASH and fatty liver, but I think it might come down to just the diabetic meds, and you control that, and potentially you will then control. It's a metabolic problem, right? It causes kidney problems, diabetes, endocrinology. Now, from the liver standpoint, what I would say is, we can cure Hep C now, so everything is moving towards prevention. All that takes time. So now, we can cure Hep C with an oral pill, 97 and 99% effective. So if you catch a lot of people early, you can prevent them from progressing to cirrhosis. And if you prevent the Hep C, then they won't get admitted, because all these patients get admitted to the hospital when they have complications of cirrhosis. Now, that being said, those patients are shifted to outpatients. A lot of the hospital medicine and primary care physicians should know this, that there's a code to bill for checking for hepatitis C. And the reason they did that governmentally, if you catch Hep C, you send them to a GI or liver doctor and you cure them. And it's that simple. The downstream revenue you save is unbelievable. Now, alcohol is still there. COVID hasn't made it better. We see a lot of alcohol in the hospital. So prevention is also important from that standpoint, but fatty liver disease is on the rise. So if we can prevent fatty liver disease, or at least prevent steatosis, which is fat in the liver, it takes about 20 years or so, 20, 25 years to get to cirrhosis. They come to your clinic and you tell them, diet, exercise, weight loss. Well, we all say that, but it doesn't mean anything anymore. If we can find meds that can prevent that progression, which might be these medicines that you talked about, then things will shift to outpatient. That's what I think.
Great, thank you. Any thoughts?
Yeah, I think two things. One is cancer patients are living longer now, and so they're getting heart disease, and they're getting heart failure. And so I think you're right. You're seeing patients in the hospital now who are, they've got CHF, they've got stage 4 breast cancer that they've had for 8 years, and they're on 6th line therapy, and they have kidney disease too, and so yeah, I think they're getting more complicated. They're getting sicker because they're living longer, and obviously that's a good thing. That places increasingly more challenges on the system. So I don't think that's going away, because we're getting people therapies that are prolonging their life, and so the other things like heart disease and kidney disease are starting to become the life-limiting conditions. I think the second part of that, though, is that, especially with these new adaptive cell therapies, they're starting in the hospital now, right? And so, whereas we want to get our patients out of the hospital and not have them in the hospital, they want to get in the infusion center and live as outpatients. A lot of these therapies need monitoring up front in the hospital, and that's there are programs now that are doing some of these cell therapies as an outpatient. I think that just is going to require a lot of very, very kind of careful monitoring inpatient. And that's an example of where the outpatient-inpatient collaboration will have to be very tight to do it well, because you can't have somebody on the outpatient side who shows up in cytokine release syndrome to the ER and is not recognized, right?
Perfect. Just one last question before we break the fireside chat, which is, we have this theme today about the collaboration, and what's your advice about creating optimal collaboration between yourselves as specialists and the hospital-based teams? So I talked about inpatient to ambulatory collaboration and so forth. Dr. Christensen just hit on that. But how about between the specialist and the hospital-based teams?
Yeah, again, that's going to be a major goal, because take, for example, the SGLT2 inhibitors. Like you said, it's still uncertain who's supposed to own those.
Maybe nobody will.
Maybe it's becoming more ubiquitous. Yeah. But does the nephrologist start it? Does the cardiologist start it? Or does the endocrinologist start it?
Or liver
now. We're talking about it too, yeah.
And it's the same thing, for example, with potassium management. We have these new potassium binding drugs that can enable the use of RAS inhibitors. But oftentimes, the nephrologist will start it, but then the cardiologist, the potassium edges up. They kind of stop it. So we do need to have better communication between the specialties. and to have these more collaborative clinics, or a clinic where you actually have the input of all those together, perhaps could facilitate people to be maintained on these drugs that are so effective.
Great,
Yeah.
great comments.
Yeah.
Yeah, I would echo that same sentiment. One other part is, if you think about the collaboration, actually UT Southwestern does a great job. They have a metabolic division. And so what that will entail is different specialists that join that division. Nephrologists, endocrinologists, actually liver doctors. I trained over there. And so when you do that, then the collaboration, it really makes it much better, so you can treat patients in a multidisciplinary form. One other thing for collaboration, this might be a good or bad thing, I still have the jury's out. With the EMR, there's a lot more digital collaboration. And so I think through COVID it kind of accelerated. Our EMR, and I'm sure a lot of you use Epic, you can actually text each other on there and get to the doctor of record. It's all part of the chart, although now when your phone pings all the time, you kind of ignore it because it's one of those things, right? So I don't know how that's going to play out. The digital era is here. You can collaborate, get in contact with anyone. Back in the day, you couldn't. I still am a little old-fashioned. I was in the transition of training where we would actually pick up the phone and call the doctor, so that never hurts. So I'm always welcome for those calls.
Great, thanks. Any last comments, Dr. Christensen?
Yeah, I mean, I've already talked about the importance of the outpatient physician and coordinating with them when they're in the hospital, early on, because that helps. They can help maybe with management, but also talking about the inpatient side, so I'll pivot a little bit to the inpatient collaboration. I'm old school a little bit in the sense, and I'm not obviously old school, but I'm old school a little bit in the sense that, there's just not a substitute for talking.
Exactly.
There's not a substitute for going, for asking the question. And I do a lot of messaging through the EMR to consultant or to primary teams, and that's useful. But I just think you pick up the phone and you're just asking the question, hey, XYZ is happening. Like, could this be related to this XY? And maybe the answer is no, right? So I think that we can become overly digitalized. That's a side, and I think you cannot. Collaboration, I think, has to be communication, and things are lost when you're texting, right?
Yeah.
You just can't.
But it's going to go that way.
You can't.
It's an important point. Think about how much is lost when you email, and how things sometimes get misinterpreted just from email. So great. Well, this was a wonderful fireside chat. I'm gonna let our esteemed speakers go, except for Dr. Rahimi. He doesn't get to break away. But please give a round of applause for Dr. Palmer and Dr. Christensen and Dr. Rahimi. All right, well, wait. Before you guys go, sorry, I want to do this post-test really quickly. I apologize. Let's see, and each one of you is this the first one? Mm-hmm. All right, how does the observed increases in plasma EPO level compare with ESA and HIF-PHI treatment? Dr. Palmer, before you run, let's see how they did. Go for it. All right. Well, they moved to the last answer. Thoughts?
I think that's a good improvement, and again, it's much more physiologic. That's the key. Moderate, much more physiologic.
Great. Thanks, Dr. Palmer. Let's go to the next question.
That's not fair for me. My question.
Yours next. A patient with HER2 positive advanced GI cancer treated with trastuzumab presents to the emergency department with shortness of breath, dry cough, and chest pain. Patient explains symptoms are causing interference with activities such as shopping and preparing meals. What grade of adverse events are we dealing with? 2, 3, or 4? All right. Well,
Yeah,
what do you think? They went down a little bit.
Well, honestly, there's not a. I think this is a tough question because if the patients come into the ER, if they're hypoxic, then they're probably going to be grade 3. They're going to be admitted. If they're not, then they're maybe more grade 2. So I think they're both right. And
There you go.
So almost everyone got this question right for that reason. But yeah, I think that it could be one or the other. And remember, grade 3 events are going to be people in the hospital. So if they need to be admitted, they're at grade 3.
Well, the good news is grade 4 went down to 0%.
Yeah, they're not
How's
in the
that?
unit yet.
Yeah.
So maybe they're getting tubed. I don't know.
Good. All right. The last one is we're going to let Dr. Rahimi deal with this question through his lecturing and so forth. But let me let you just answer this. Go ahead. Can we start the music and let them answer this question about the role of lactulose and rifaximin? Prevention. Do you do it in the first 6 months, after the first 6 months, or at any time? All right. Well, it looks like, it's the first 6 months is the right answer. Obviously, you haven't had the lecture, and so Dr. Rahimi will have a conversation with you around that. Thank you. Thanks, Dr. Christensen.
Yeah, thanks.
All right. While Dr. Rahimi is getting mic'd up, his talk is going to be on evidence-based care and therapeutic updates to reduce the